Hi everyone. I hope everyone is doing well today. I want to thank everyone for your patience and whatnot last week while I was away. I actually haven't had a vacation, a real vacation. Actually, I haven't had a real vacation because I was still working last week, but it was the closest I've had to a real vacation in probably, I don't know, 15 years or so. So it was very nice to be able to get away and shut down a little bit while I was away. So I do appreciate your patience, and hopefully I was able to get back to everyone within a reasonable time frame. And I think that at this point I've answered everyone's questions. But if there was anything that I missed, please let me know. But I had answered everyone's questions. I had one that I did have to get back here to answer, and I think that I've gotten back to that. If there's anything that I missed, please just let me know. Um, Also, I did want to follow up on one topic, I guess, from last week with regard to bad debt, because it seemed that there were some questions out of the Ed Puzzle summary from that. Some of the when people ask a question at the bottom, so I want to touch on that. But first, I'll touch on the our discussion. Well, last week was obviously we talked about Medicare, Medicaid, which is one of my areas that I really focused on in my career in compliance. That's where you focus, Medicare, Medicaid fraud and abuse. And so our discussion for the week was with regard to Medicaid expenditures. And as I'd mentioned in the announcement yesterday, uh, there was kind of a couple of different ways folks thought overall. I mean, there were lots of great ideas, but there were a couple of different ways folks thought we could probably combat this increase in overall expenditures that have continued to rise. But some of it is related to the Affordable Care Act, obviously, because there have been an increase in people going on Medicaid because of the expansion. So that's part of it. But there also has been, even if you look back at the time before the ACA, Medicaid expenditures have been increasing over time. And so, what is the way that we can kind of put a halt to that? And some great ideas about wellness, making people more well, to avoid emergency department visits, to avoid unneeded hospitalizations for patients that are perhaps chronically ill. These are all great ways to hopefully combat some of that increase in expenditure. But one of the other issues that many people mentioned and is a problem is fraud and abuse in the Medicaid system. There's fraud and abuse on the patient side, from folks that maybe aren't eligible for Medicaid, or maybe there's other types that aren't eligible, but fake eligibility standards, or fraud and abuse in the way they use the system. So there's fraud and abuse on that side, but there's also fraud and abuse on the provider side. So there's as much. Everyone seems to talk about fraud when it comes to Medicare, because Medicare pays better. So a lot of people are trying to defraud the Medicare system because that's where it's an easy target. You can get a lot of money out of Medicare as a provider. But there's as much fraud and abuse going on in Medicaid, and providers submitting claims for not medically necessary services, upcoding services, submitting claims for services that simply weren't done, those types of things. So those are all increasing our expenditures as well. So all types of things that are problems. So a lot of that, and the reason why I was holding off on my bad debt conversation, a lot of those things cause hospitals, all of these expenditures, especially with Medicaid, cause hospitals to have a good amount of cost is a certain amount. So it costs X amount of dollars to provide services to a Medicaid patient. And unfortunately, depending on your state, it's not the same everywhere. But depending on your state and the types of services you're providing, unfortunately, cost is here. So this is how much it costs to provide service to a Medicaid patient. And oftentimes, the amount Medicaid is paying you for that service is somewhere down here. So there's this this extra amount in here that's not quite being met. That's not always the case. I have a friend that actually is a licensed certified social worker in Pennsylvania. I'm here in New York, but I live actually 5 minutes from the PA border. She lives in New York. She chooses to provide services in Pennsylvania because in New York she would get paid $15 for her service, and in Pennsylvania she gets $100 for her service for the same exact service. So every state has a different schedule that they pay on. Now that's a professional service. Hospital services do tend to be a little more similar in that the majority of them do pay much less than cost for the Medicaid programs. But in any case, so we have this cost, and we have beneath that somewhere around what Medicaid is paying. So it's hard. Hospitals are losing money on these patients. Then we have other patients that come in. Maybe I come in for my for a service, and maybe I'm a high deductible health plan patient, which means I'm a private health plan patient, but I'm on a high deductible health plan. Maybe my deductible is $2,000. So I come in for my service and I owe $2,000. If I don't have that $2,000, maybe I just choose not to pay it, which of course does not happen. But if I just choose not to pay it, that's eventually going to go to bad debt. Now, it doesn't mean that it's charity care. I haven't applied for it. I wouldn't meet the requirements for any charity care services. I'm not in a financial assistance program. I'm not eligible for any government programs. I am just straight out bad debt. Now, what we had talked about last week was that we were talking about the community benefit standards and all of those types of things, and that should that bad debt, those dollars, like that $2,000, should hospitals get credit for that within the community benefit standards, to work toward their tax exemption, to work toward becoming their not-for-profit status. And what the American Hospital Association says is, yeah, that's a loss they're taking, and ultimately it benefits the community. They're not collecting that money. Someone in the community benefited from that, so it should count. But unfortunately, it doesn't. Bad debt, although the government does assist with some bad debt payment with a bad debt and charity care amount, they do get some money for that. But something that's just plain old bad debt, such as that $2,000 payment that I chose not to pay, does not help a hospital to work towards their not-for-profit status. Charity care does, where if I owed the hospital $2,000 and I had no job, or I had a low-paying job where I had applied for their financial assistance program, and I was on that, then that may work toward it. But a straight-up bad debt, unfortunately, does not. Okay, so I think that's what I wanted to cover this week. As always, if you have any questions, feel free to put them in the summary at the bottom thing. But if you have questions that you'd like answered more rapidly, please feel free to email me, and then I can always, if it's something that I think might be interesting to everybody, I'll get something out, via the announcements. Always be checking those announcements at the front of the classroom. Right on that main page. I'm also going to be sending out, actually you'll get it probably before you see this. I'm going to be sending out the synchronous sessions, and when we'll be having those. I still don't have everybody's back, but we're just going to choose sessions based on the majority of what we have. So our quiz this week. We had a couple problems with the quiz. We had 2 questions. I went through all the questions that people got wrong. Because I had a couple students that had mentioned that there were problems with some of the questions. So I went through every question that students had gotten wrong, and unfortunately I couldn't do that until I got back here because this is where my book was. So I went through every question, and there were 2 questions that I didn't like. The first question, I gave credit to everyone for these questions. So the first question was, which law extended expiring program authorizations and appropriations, including the SGR, for physician reimbursement under Medicare? So this question, the answer was just flat out wrong. So the answer that was correct in the in the quiz system was MACRA, and that's not actually accurate. MACRA actually abolished the SGR. So what the SGR did, it was to try and simplify it a little bit, so physicians get paid a certain amount under Medicare. They get paid under a fee schedule. And each year for many, many years, there was the CMS was threatening to drop this by this rate, the sustainable growth rate. They were threatening to drop it by like 25%, a significant amount, enough that the physicians were up in arms, rightfully so. So each year it would come to the point where that was actually going to happen, and Congress would actually intervene. There would be an act of Congress to stop this from happening. And then finally in 2015, MACRA went and abolished the SGR, thank goodness, so we didn't have to go through this 11th hour congressional action every year to get this this drop to not happen. Now, if you read the question exactly as it appeared, which law extended expiring program authorizations and appropriations, the answer would have been Protecting Access to Medicare Act, or PAMA. So the correct answer to the question as it appeared was the PAMA Act in 2014. That actually extended it one more year, and then MACRA abolished it. The bad part about MACRA was that it actually also delayed the implementation of ICD-10. So it was a great act in one regard and a really bad one in another regard. But so that was that one. I did go through and give everyone credit for that. And you won't see it. It'll still show as a red check mark, but you should see the 2 points there. The other one that I gave credit for, because it's worded really poorly, and when I read it the first time, I'm like, no, that's right. And then when I read it again, I said, no, its question doesn't make any sense. So the question was, which of the following is not an eligibility requirement for Medicaid? And to be honest, I didn't even read exactly what the book says. So it may, based on the book's wording, it may read to meet something exactly in what the book says, but I don't like the question, so I gave everyone credit. Income, age, and gender all have some play in with regard to Medicaid. So there are programs that are specific only for patients of a certain age. There are some Medicaid programs that are specific only for patients of a certain gender, because there are some programs that are only for pregnant women. And then obviously income can have typically has, but not always, because some Medicaid programs are based on catastrophic illness. Some Medicaid programs are based on the disability, etc. Those are still based on income. But the catastrophic illness one is the one that I can think of that sometimes is not, income is not at the top of the four. But in any case, I just thought the question was worded really poorly, so I did give everyone credit. But do keep in mind that there are Medicaid programs that are focused in all of these different areas. Obviously, the main focus of Medicaid is for patients typically of low income that don't have access to other coverage. So Medicaid is the payer of last resort. They don't have group health plan. Maybe they work somewhere, but that payer doesn't, or that employer doesn't offer coverage, and the patient is not at a high enough income level that they would be able to buy into one of the group health exchanges, like through the Affordable Care Act. So that is the population typically that Medicaid is focused on. But so keep in mind that sometimes gender does play a role, especially in the pregnant women that Medicaid can assist. Sometimes age plays a role when we're talking about the Children's Health Insurance Program, because children are only eligible up to a certain age, or when we're talking about the programs that help patients that are also on Medicare, dual eligible patients, because you have to be a certain age to be on Medicare, or you have to be disabled. So there are times when age and gender do come into play, but it was a poorly worded question. So I did go through and give everyone credit for that as well. And I do apologize for any of these questions that are confusing or difficult. I this is the first time that we're trying out these questions, so I'm not going to say that you're guinea pigs, but you might be guinea pigs a little bit. This is the obviously the book was written in 2018, so this is a new textbook for us, new version of this textbook. So these are new quiz questions that were provided as well. So I do apologize for any of those, and please feel free if you have a question on a quiz question. I think you've figured out by now in week 5 I'm pretty flexible, so please feel free to ask me. I'm happy to dig into it a little bit and explain what the thoughts were. We didn't write them, but I can dig into it a little bit and dig into the info for you. Okay, next question. So those two everyone got credit for, but I did want to provide a little more info on them. Next question. Balanced Budget Act of 1997 established blank, the managed care option for Medicare beneficiaries. So the answer was Medicare Plus Choice, or Medicare Part C. And so that was the correct answer. And it's also sometimes called Medicare Advantage, and that is the kind of the managed care version of Medicare. So some patients just have Medicare Part A and Part B, which is what is kind of known as traditional Medicare coverage. Or when you maybe sit around and watch TV and you'll see ads on TV for Medicare coverage. I'm not sure exactly, for those of you that are in the Western Pennsylvania market, I don't know if UPMC offers one, they may, or Highmark, if they offer a Part C plan. But I know here in New York, United Healthcare used to offer one. I don't watch much TV, so I don't see them much anymore. But you would always see these ads, especially around open enrollment time, to try and get patients to transition over to these types of plans. So oftentimes it'll offer the patient a little more in the benefit realm than traditional Part A and Part B. It'll sometimes give them some dental coverage, sometimes give them some vision coverage, sometimes it'll even give them coverage for things like hearing aids, things that aren't covered on traditional Medicare coverage. So it is sometimes a little boost for them, and it sometimes will cost them more too. There are some plans that don't cost them anything more than their regular Part B premium. But there are some plans that do cost more, but they have more benefits, so that is a benefit to them as well. So that is our Medicare Advantage, Medicare Plus Choice, Medicare Part C managed care plans. Next question. The donut hole, as created by Medicare Part D, refers to, there's a cadre of answers, I won't read them all. But the correct answer was a gap in coverage requiring beneficiaries to pay out of pocket for all prescription drug costs that fall between a certain cost range. And this is Medicare Part D is obviously the Medicare drug program. And the donut hole is honestly a horrible thing that is part of Medicare Part D, part of their program, where drugs are covered up to a certain point, and then there's this gap in coverage where then the patients have to pay out of pocket. They literally have to pay out of pocket for their drugs, not a copay, they have to pay an out of pocket full cost of that drug, and then it'll kick in, the coverage will kick in again. It can be a problem for Medicare patients, because we're talking about Medicare patients that are typically on very limited incomes. And it can be definitely problematic for them. So there have been many attempts to try and fill the donut hole with different coverages, etc. But so hopefully at some point they'll figure that out. But right now they have not quite figured out how to fill that donut hole. Last question. Fraud is defined as. There were 4 different answers, but the correct answer is intentional misrepresentation of fact. So those that got it wrong just chose unintentional misrepresentation of fact. Just a small, may have just been looking at the answers, quickly and choosing the wrong one. But so oftentimes we think about fraud and abuse. with regard to healthcare. So when we think about fraud, fraud is going to be, obviously, like this says, intentionally misrepresenting something, doing something purposefully. Submitting, like when we were talking about submitting claims, defrauding Medicaid, submitting claims to Medicaid for services that, let's say I'm a provider and I submit claims to the Medicaid program for services I didn't provide. That would be fraud. I am intentionally misrepresenting that I actually provided those services. However, on the flip side, we compare that to abuse, because we always compare fraud and abuse. They're always paired together. Let's say that I am a provider and I submit claims to Medicaid, and I'm performing office visits, and I'm performing a fairly low-level office visit. We'll say a level 2. Visits go from level 1 to 5. So I'm performing a level 2 office visit, but somehow, because I'm working quickly, not paying attention, whatever, in error, I end up billing a bunch of them as a level 4. So I get paid more on those. Now, if I do that over a long period of time, that could be considered abuse. So I'm not intentionally misrepresenting the facts. It's more of an error on my part. But if I do it once, that's just going to be an error. If I do it, if it's negligence on my part, and I continue to act negligently, that can be considered abusive. So that's why oftentimes providers have, they may have coders, hopefully they do, that are checking for these types of things, but they will have compliance folks that are reviewing claims, reviewing financial arrangements, whatnot, to make sure that there isn't fraud and abuse going on in their organizations, because it's obviously providing great clinical care is the main focus, but if you can't maintain your business operation, then you won't be able to provide great clinical care. So making sure that all of these things are happening in the background keeps the doors open is a really important part. Excuse me. So, okay, so those were the questions that I had. If anyone has any other questions on any quiz questions or any of the other information from this week, please let me know. If you check, I did go through all the quiz questions and added those points, but if perchance you found that if you don't see them, please let me know. But I did go through them a couple times, so they should be there. And other than that, I will, there are still a couple of, I do have a couple papers outstanding yet, so I will get those done. Unfortunately, probably not today. Probably I'll get some of them. I have a few to go, so I'll probably get some done today and the rest done tomorrow. And that's about it. So any other questions, let me know, and I'll see everyone in the discussion boards. Thanks.